Hello, everybody, and welcome to today's webinar. We are just going to give a couple minutes to make sure everybody gets in from the waiting room, and we will get started. Just give me just a minute so we can get everybody in here. Thank you all so much for joining us today. We'll wait just another minute. We still have quite a few people trying to get in from the waiting room. Thank you again for your patience, and we'll get started in just a moment. Okay, we're starting to slow down a little bit, so I'm going to go ahead and get started. Thank you all for joining us today with our joint webinar with CS Medical and partnering with the Leapfrog Group. We are going to be talking all about improving your high-level disinfection and infection prevention processes today. My name is Jill Holtzworth, and I'm an infection preventionist and the medical affairs manager for CS Medical. Just a couple things before we get started. If you have any questions at any time or you have any trouble, please go ahead and drop those questions or comments into the Q&A. We have staff on standby with Leapfrog and with CS Medical that can start answering those questions right away. We also are delighted to let you guys know that this presentation is approved for 1.0 IPU from the Certification Board of Infection Control for IPs, as well as 1.0 CEUs through HSPA for sterile processing. And we will give you more information at the end. Again, my name is Jill Holdsworth, and I've been in IPE for about 16 years. I am a CIC certified infection preventionist and a fellow of APIC. I'm also certified through HSPA as a sterile processing technician with my CRCST, as well as a certified healthcare leader through HSPA. I have my master's in exercise physiology through Marshall University in West Virginia. And I started out as a cardiac rehab technician and did rehab in St. Mary's in Huntington, West Virginia. I've been a member of the APIC board and I'm currently serving on the CBIC board of directors. All right, let's get started. Our objectives today are to understand the Joint Commission and the DNV requirements related to reprocessing and infection prevention. We want to discuss the common regulatory citations that we all might face, as well as the barriers to compliance in relation to high-level disinfection and sterilization. We want to talk about transport and storage of your ultrasound probes, scopes, and surgical instrumentation, as well as describing solutions to some of these common barriers that we're seeing. and talk about patient safety concerns, compliance issues related to high-level disinfection. That includes manual cleaning, storage, and transport. Now we are going to start with a poll question. I'd love to see who is joining us today out there. So we are going to ask our friends at Leapfrog to put up this poll question for you. Please just pick whatever closely matches what your current role in your facility is. And we'll give you just a moment to complete this poll. We'll give you about 10 more seconds and then we'll show the results. All right. So it looks like we have quite a bit of infection preventionist on the line today, which is great, and some sterile processing, lots of department leadership, and lots of quality folks. All right, great. Thank you all for being here. We're so happy to have you to talk about this important topic. All right, so I'm going to start with just describing all of the steps that it takes to be successful when we're talking about ultrasound probe reprocessing. And when we are talking about ultrasound probes, this includes your TEEs, your transvaginal, transrectal, and any surface probe that you have deemed that needs to be high-level disinfected. So we are talking about first needing to have that point of use cleaning at the bedside where the procedure happens. That has to be your first step. Then we're transporting that soiled probe. You have that manual cleaning. You have the rinsing and drying. We also have high-level disinfection, then rinsing and drying again, the storage and the safe transport to the next ultrasound procedure. Next slide. I want everyone to first familiarize yourself with all of these AAMI standards. And as we're talking about these, if you see an AAMI standard that you are not familiar with or you haven't read yet, then jot it down, make a note that you either need to make sure you have access to it or you find it. There is a good chance that someone in your organization may have already gotten this standard or have access to it. But these are the things that as hospital administrators or as infection preventionists, SPD professionals, we need to make sure that we have a good grasp of all of these standards so that we make sure we're doing the safest, the most appropriate, and the most successful things for our patients to have a safe procedure and a safe experience. AAMI ST79 is a very well-known standard for those in sterile processing and hopefully infection prevention. These are the kind of basic level of standards for your steam sterilization, your instrumentation and sterile processing. This is where you find your soil transport standards. So this is a really important one to know. You also have ST91, which is everything about endoscope reprocessing. So for those of you that said you were joining us from an endoscope area, I assume that you know these standards very well, which complement the SG&A standards. ST108 is a newer one. We used to have TIR 34, which was all about water quality. Now it's a standard ST108. If you're from IP, sterile processing, facilities, even quality and department leadership, ST108 is imperative for us to know more about the water quality that we are using for medical device reprocessing. It's so important that we have this right. And this is different from your water management plan that you're using for your entire facility. Sterile processing and your areas where you're doing device reprocessing really needs to have either its own type of water management plan its own team, which is described in ST 108, that includes your infection preventionist. It includes someone from your device reprocessing area because it's different. It's not just the Legionella prevention plan and all of those components that are also very important for the rest of your facility, but it needs to be its own separate space and thought process. ST58 is one that's often not studied as much, but your chemical sterilization and high-level disinfectants. This is very difficult to understand, so you need to take a little bit a little bit more time to understand this one sometimes. And then ST90, there's a lot of quality folks on the line here, so this is all about your quality management systems. So really take a look at this one and understand, what should we be doing for quality management in sterile processing, and what is Amy suggesting that we focus solely on your sterile processing departments? Next slide. Okay, so looking at what Amy calls the TIR. So these are technical information resources. So these are kind of guidance documents. So one that we look at a lot with our endoscope or our probes and our TEEs is TIR 99. This is one of the newer TIRs, something that I wished for a long time as an IP. So this is something that includes dilators, TEE probes, and ultrasound probes. So very important that we know this one. 109, if you transport medical devices externally, that's going to be very important. But I'm going to go down to PB70. This one is very important because this is your protective barriers. And the reason I bring this one up is because this is going to speak directly to what your reprocessing staff must wear at minimum to make sure that they're protected. And the reason I bring this up is because we see a lot of strike through, which is that kind of wetness that goes through the gown at the level of the torso where they're leaning against the sink. So if you have strike through on your gowns, then we want to make sure that they're wearing a gown that's protective, that's not potentially exposing them when they're leaning against the sink. I have recommended to people strike through should be a safety event going into your safety system. The PB70 document calls out decontamination gowns specifically now in this new update. It says that you must have AMI level 3 at minimum in all of the critical zones listed. So get a copy of PB70, make sure that you're keeping your reprocessing staff safe, and make sure that you have a gown that is at minimum an AMI level 3 per the standards. Next slide. And I included this slide in here. This can be a great reference for you as a great workflow document that with your ultrasound transducers. So looking at especially that non-sterile gel, the sterile gel, a lot of us have heard about this in the past 2-3 years about some outbreaks with sterile gel or non-sterile gel, moving to sterile gel. When should you low level disinfect? When should you high level disinfect? So this is a great outline that you can use about when do you have to do certain things? When should you use that sterile gel? And really using this as a guide with when you should do certain things. Okay, next slide. Now let's talk about Joint Commission for a moment. I know there's a lot of quality and department leaders on here, so we really want to make sure that we are meeting our regulatory guidelines, which are now crosswalked with the CMS standards as well. So when you see this ICO 40101, we want to make sure that the policies and procedures are in accordance with the following hierarchy of references. And I'll show you an image in just a moment that is really important. So, of course, that means applicable law and regulations, the IFUs, which we'll talk a lot about today, and nationally recognized evidence-based guidelines and standards. So we're going to include the CDC for that, for your infection prevention and control practices in all settings. And in the absence of these guidelines, expert consensus or best practices. So your AMI standards are consensus documents, and we'll go over that in the next image as well. These guidelines have to be documented within your policies and procedures. And what I do recommend everybody think about when you're putting your policies and procedures in place to not back yourself into a corner. You don't want your policies to be so specific that when Joint Commission does come, if your policy says that you do something a certain way, that is what Joint Commission is going to survey you to. So make sure you're very careful with how you write your policies. Next slide. And this is that image I wanted to show you. And this is from the Joint Commission. So they want you to make sure that you understand where everything kind of falls in line. So those IFUs are pretty high up, right? We have to follow those IFUs. And this is really important. And to make sure that we're following those IFUs, especially in these pre-processing areas, one of the things that I recommend the most is to spend time in those reprocessing areas so you really understand what these staff members are going through, especially for those of you that are in leadership positions. It means the world to them to come and really look at all of the different steps they have to go through to follow these IFUs and ask them, how can I make this easier for you? Where are the steps that could go wrong here? There are a lot of chances for human error in ultrasound probe reprocessing. And that's where we can come in and help with that. So really go to them, ask them how you can help, ask them where they see the pain points, because that can really help your organization, your patients, and make your teams feel that you're involved, you're helping them, you're helping their employee satisfaction. But those IFUs are really important. And when you start reading those IFUs, you'll see how difficult they are, how different they are, which is another completely different conversation about how we're making this as difficult as possible for everybody. Next slide. So let's start with the basic definitions of what we're going to be talking about today. So the definition of cleaning. Cleaning and disinfection are completely different. And so I know a lot of you on this call, especially those IPs, know that cleaning has to happen first. When we're talking about surfaces, environmental services, we have to clean up this stuff first, right? Before we start disinfecting a room. The same goes for instruments and probes, scopes, all of the devices that we're using that we have to high level disinfect or sterilize. We have to clean first. So the CDC definitions of cleaning, you have to remove that visible soil. You cannot disinfect something that's still covered in visible soil. So first we're cleaning, and cleaning is that most important step that cannot be skipped. And everybody needs to look at those IFUs and see what is the IFU saying I have to do for cleaning. Some of them are going to have you soaking for a certain amount of time. Some are going to require brushes. And this also requires you to really look at that probe and look at all those cracks and crevices that are present on those probes or indentations where you're connecting things, because that's where those biofilms are going to form. And you're going to have that risk for transmission from patient to patient. Some people will skip cleaning because they think that, oh, it looks clean. I had a sheath on here, or I had a condom on here, and I'm just going to go ahead and put it in the high level disinfection. But we know you can't see what is on something but before you clean it. So you have to clean it. It is not a skippable step. Even if you are covering it with something first, it still has to be cleaned first. So not an option. When you're out there auditing these processes or observing, you must make sure that cleaning step is done and it's done well. If it's not, you are going to compromise the high-level disinfection process. So when you're disinfecting something, this is obviously that step that removes the pathogenic microorganisms. But then when you take it a step further, that low-level disinfection, for some of you who aren't as familiar with some of these terms, low-level disinfection is going to be using kind of your normal disinfection wipes. So something that you're using, on an everyday basis. And then your high-level disinfection is going to be that 6-log kill. So we're destroying and removing all those microorganisms. All right, next slide. So let's talk about inspection and transport. So as soon as you do the procedure, we're going to be pre-cleaning, and all this time we need to be inspecting. Probes sometimes get ignored when we're talking about inspection because they seem pretty smooth on the surface. They don't seem like they need the inspection that a metal instrument needs to have, right? But that's wrong. We need to make sure that we are inspecting these probes for damage, for cracks, for little small tears, micro tears, because anything that's compromising that probe, either on the shaft, on the cord, anywhere, can be a great place for bacteria to settle and biofilms start to form. So, trying to protect these probes from damage is of utmost importance. So we are removing that transducer cover. We're immediately cleaning with something like an enzyme sponge or some kind of disinfectant wipe. We need to remove any gel that might be present, visible soil, and we're disinfecting that transducer. Transporting that probe is really, really important. And we hear this from a lot of people. We see it. We see lots of things that are inappropriate transport methods. I probably see the kind of Tupperware box or bin the most. We need to make sure that we are transporting per AAMI guidelines, that we have something that's going to separate the two pieces of the probe. So the actual probe itself is high level disinfected. The rest of it is low level disinfected. So when you are transporting that soiled probe as well as the clean probe, you cannot let those two sections of the probe touch. Same goes for when you're storing it, which we'll talk about later. But you have to have a method for transporting these probes, TEEs, ultrasound, rectal, all of them, to where the low level and the high level disinfectant pieces do not come in contact with each other because it is a completely different type of disinfection that's occurring. So, do you have a method that you can say they don't touch, they don't come in contact with each other? And if you don't, you need to look to see how you can do that, or you are compromising the entire process. So, we have some of these types of things that we can walk you through, but things like a pillowcase, we patient belongings bag, trash bag. We've seen lots of different things. The Tupperware containers, those kinds of things are not suitable. They're not appropriate to be transporting these items in. Next slide. And I said some of these things, pillowcases, trash bags, plastic bins. I've said so. I've seen it all, I think, by this point. These things also damage these probes. Some of you on this call, department leaders and senior leadership, you know how much these probes cost. You probably also know how much these probes cost to send out for repair. So when you properly transport these items, you're going to save yourself a lot of probe repair costs because you are properly securing these items. They're not going to be banging around. There are small little crystals in these ultrasound probes that can be damaged very easily. If they just hit the sides of these bins, they can very easily damage and those crystals can be damaged. So the more we can protect these delicate probes during the transport process, the better we are at saving ourselves the money for probe repairs or having to replace the probe altogether. So we also need to make sure that we're protecting ourselves from those biohazards and when we keep using the probes after we transport them incorrectly, if we have something that can't really be cleaned out effectively or just keeps contaminating things, then we risk that cross contamination. Next slide. So if you look at AAMI ST 91, there are lots of statements in the AAMI standards, and I've just listed some of them here. But again, if you're not familiar with these standards, please go and find them and read them. But when we're talking about manual high-level disinfection processes, the AAMI standards say that it's not recommended. So if you have a facility that is currently manually soaking for the high-level disinfectant process, then really use the AAMI standards to your advantage because this process, not only is it a regulatory nightmare as an IP, this is something that we have tried to get rid of in our facilities for many years because it is such a difficult process to do correctly and do safely. So if you still have big bins, I've seen blue ones, big circular blue bins that you're soaking in, or these tubs that you soak in. It's just not recommended. If you have a low resource facility or limitations in your facility that you just can't do the HLD in an automated fashion, then okay, if that's your only choice. But it is very, very difficult to do this correctly and of course safely. You have device compatibility with a chemical that you're manually soaking. The temperature and the timing is very difficult. You have to keep the chemical in one of those basins at a certain temperature the whole time you're soaking, and you can only soak it for a certain amount of time. And a lot of people forget about them or they walk away. Then you're overexposing those probes, and that can lead to probe damage, or you can underexpose it. You may just kind of put it in there and think it's in there for 10 minutes or however long, and then you're not killing what you need to kill. There's a lot of PPE required, a lot of PPE changes as you move from one step to another. The type of container, of course, you can't just use any type of container. The rinsing is so important because you have just soaked that probe in a container of harsh chemicals for a long time. And the chemical needs to be rinsed per whatever the IFU says, which sometimes can be 2 minutes, 4 minutes, and then you have to do it again. Some of this says that you must have critical water. Do you have critical water where you're doing this? And if you don't, you're not going by the IFUs. Even if you don't have critical water, are you able to spend the time to rinse for 2 straight minutes twice? Are you actually going to do that? Can you time that? And these chemical test strips, I know any of us that have gone through a Joint Commissioner DMV survey, we know about these chemical test strips, the expiration dates on these test strip bottles. We know what a pain that is, and that we've probably been cited for it at some point or the other. Amy TIR 99 also says manual high-level disinfection is not the preferred method because it is a safety hazard and there are concerns for users. And there's such an inconsistency in process from person to person. So if you can automate even just the high-level disinfection process, we want you to do that because it is safer for the patients, it's safer for the processing staff, and it takes care of a lot of that human error and inconsistencies in process. Next slide. One thing I really want to make sure that we all understand, and it sounds very simple, you cannot rinse, clean, or do anything with an instrument in a hand washing sink. I know this seems intuitive, seems like it shouldn't happen, but it happens. It happens everywhere, especially if you have an automated high-level disinfectant machine in a clinic room or in a patient care space, and it's there, it's easy, you only have one sink. How are you cleaning? And if the answer is, well, we clean in that sink and that's also our hand washing sink, that is not okay. That cannot happen. So you have to figure out a different process if that is what you are doing. So we need to make sure that if you have your cleaning being done in a clinic or patient space and there's only one sink, you're going to have to rethink your process. This is a non-negotiable. You cannot do this. So as you're rounding, as you're observing your process, think about how they're actually ask them, how are you cleaning? The answer also cannot be we don't clean, we just put it straight in the machine. So really ask a lot of questions. Figure out how you're going to do this. Be compliant, be safe. Next slide. So I want to show you some of these pictures with what can happen when you don't do these processes correctly. So sometimes in facilities, we use the wrong chemical. Some people aren't sure what to do their manual cleaning with, like what to put in the water. And even when you're just manually cleaning. So you've automated your high-level disinfectant, but you still have to clean. Even when you are manually cleaning, sometimes we're not using an approved product. So approval of chemicals is so important because you can damage your probes so quickly. So these are some probes that the wrong chemical was used somewhere along the line of the process. And I know some of you are probably cringing, thinking, wow, they just ruined that very expensive probe. Now they've got to replace it. These are not recoverable in some terms. So maybe that top one, maybe we could replace that. But sometimes you can't recover these and you just have to replace the whole thing. So making sure that we're doing these processes by the IFUs with approved chemicals is so important because that picture on the bottom there, you can see all those little grooves. That's a great place for bacteria to hide, live, grow, form biofilms. So we have to make sure that those IFUs are being followed. Next slide. So let's talk about cost. So here's some other pictures to the left of some probes being damaged. So these could were most likely from overexposure. It'll just eat away. Those chemicals will eat away at the surfaces of these probes if you leave them soaking in there for too long. So when we send probes off for repair, I used to ask, how many probes do we send off every month for repair? And it just is a normal thing for departments to send things off for repair, but they don't have to be. We can really decrease the amount of probes that we're sending off for repair if we improve the workflow and improve the processes. So let's work on that because these numbers are high. Say you're sending 15 TEE probes off for repair every month. That is a lot of money that you could do a lot more with. You could hire more staff, you could get better equipment, you could do all sorts of things. So if you could decrease some of these probe repair costs, then we could really be financially advantageous to your department. So some of the things that we're talking about here, some of these workflows, some of these manual processes could really be helpful to your department and to your workflows. Next slide. So let's talk about rinsing for a moment. So the manual rinsing, so if you are manually cleaning, then you have to do, if you're manual cleaning, you have to manually rinse. So again, the IFUs will state how many times you have to manually rinse and for how long. So a lot of times I'll see manually rinse for 2 minutes after your cleaning. So the hard part is you can't just manually rinse if in the same sink you just cleaned in. So you're going to have to drain the water, make sure that the sink is disinfected, to make it a safe process. If you have two sinks, then you have your sink to the right. Like in an endoscopy area, we have a double sink. So you can rinse in that second sink. But you need to think about all the times that you're changing your PPE. So if you're thinking about doing an ROI for new equipment or for how long you're taking with this manual cleaning step, then think about that time it takes to don and doff your PPE, all the PPE that you have to put on. And then thinking again about that critical water. Look at your IFUs because some of your IFUs are going to say potable water, some are going to say critical water. So really depending after that cleaning step, what type of water and for how long. You're also going to need to look at the rinsing after the high-level disinfection step. So if you are manually high-level disinfecting, then you will need to think about, do I have critical water to rinse this if it's required? Is it only required to use potable water? So really looking at that as well. And I did see a comment just now about there are some things, and I realize there are some newer things in the endoscopy departments that only have IFUs for manually soaking, and I understand that, and it's an IP's nightmare that we're still seeing things that are only allowed to be manually high level disinfected, but let's focus on probes for now. So again, that critical water could be critical, and if you have it or not, if the IFUs are calling for it and you don't have it, then that's something that's going to need to be discussed with your leadership. Next slide. So just kind of looking at AMI ST108. So for those of you that aren't super familiar with ST108 or critical water, these are all of the things that you have to meet. If you look at that column there that talks about critical water. So this can be very daunting. It can be very overwhelming, but this is something that you can work with your facilities department. And this all depends on where are you doing your reprocessing. So some of you may be doing your endocavity and or your TEE reprocessing. Um, in your SPD department. Some of you may already have an RO or an RODI system in your SPD department, which would qualify as critical water. Um, some of you may be doing some of this in cardiology and radiology and ultrasound, which may or may not, probably not have critical water already going to that department. So if the IFUs are calling for critical water, then that is going to be something that's difficult to achieve if that's in the IFUs. Next slide. So let's talk about drying. And as I'm talking, this QR code will lead you straight to a study that I'm going to be talking about. So if you'd like to go ahead and scan that, then please go ahead. So drying of the probes have to happen in two different sections. So if you're manually cleaning, you must dry your probe after the cleaning step from the sink. And the reason why is because you cannot put a wet probe straight into a high level disinfectant. You will have water droplets, you'll have some residual disinfectant from your enzymatic detergent from the cleaning step. So the probe must be dried before you put it into that high level disinfectant so that it doesn't make the high level disinfectant inefficient. So drying has to occur, but it has to occur with something that's not going to recontaminate that probe. It cannot be with a paper towel or a fuzzy towel or anything that's going to leave lint, debris, or contamination behind. So this study that you can access on our website through this QR code shows you how we assess that through our lab. And some of these alternatives that we do see people using. I mean, paper towels are probably very easily accessible in these spaces, so unfortunately, people do use them. But you've really just negated all of that work that you just did to properly clean that probe. Something that is non-linting or low linting, or something that is a gamma irradiated drying cloth, like our quick dry cloth, would be something that is a much better option so that you know it's dry, but it's not contaminated. This same step needs to be done again after high level disinfection so that when you take it out of the high level disinfection equipment, either if you are manually high level disinfecting or if you're automating the high level disinfecting, you need to make sure that that probe is dry. Very similar to how we consider endoscopes. When we have an endoscope that we're putting to storage, we want to make sure that endoscope is dry. And I always have told people, if you go into an endoscopy department and you see chucks lining the bottom of the scope storage cabinets or towels or anything that's catching any kind of water or moisture, you know that their scopes are not dry. And it's pretty easy to tell that, right? So we need to assess, why are the scopes not dry? Why are the probes not dry before we're storing them? Because they absolutely should. So you need to dig into that a little bit more. Next slide. And I wanted to share with you this study that was done a few years ago. This was actually on endoscopes, but the point is the same. This team, Corey Ofsted and her team, did a study based on two different processes in five different medical facilities. And what they did was they looked into two types of procedures. People who were doing manual cleaning for their endoscope process and had automated the high-level disinfection process, and then facilities who had done automated cleaning and high-level disinfection. Those that were still doing manual cleaning were only 1.4% compliant, and those who had automated the entire process were 75% compliant. And that's not surprising because the manual cleaning steps are so complicated and so hard to do. There's a lot of timing, a lot of temperature. There's so much that can go wrong because it's all up to the human. And the human is busy. They're being pushed to turn over things faster. They get distracted. So by leaving things so much up to the human, we are bound to make mistakes. And so making sure that we can make things as easy as possible on the humans is going to make the patient safer, make the humans happier, and make our probes stay healthy for longer. Next slide. I also wanted to share this study, also by Corey Offstead and her team, but she did two studies called the Splash studies. And if you're not familiar with these, they are fascinating. This is a probe reprocessing area in a high-level disinfection unit. And what this study showed was that water droplets at these cleaning sinks will splash up to 7.25 feet from the sink where the manual cleaning occurred. That to me is terrifying. So some of these rooms that I have seen, the ultrasound probes and TEE probes being cleaned, they aren't even that big. So that means that this water that has detergent, microbes, all sorts of things is all over that room. And that also means it's all over the person. It's all over the clean probes if they're being stored in there. So some of you have your clean probes hanging on hooks in these tiny rooms. And so this water and all these microbes are splashing all over the place. Some of you are cleaning your probes in the clinic rooms and patient rooms. So that means you're splashing on the equipment and the patient exam table or the bed. So this is a huge risk. This is a risk to not only you as the reprocessor, this is a risk to the patient equipment, the patient room. So this concerns me a lot. So if you haven't read this, this is open access through AJIC, the American Journal of Infection Control. And I would take a look at it and really put it into the space in your head of what would this look like in this space that we're doing ultrasound probe reprocessing or TEs, and think about how far those droplets are really going and what they're falling on. That is the terrifying part to me. What are these droplets actually falling on? And are we cleaning all the spaces after those droplets are falling all over the place, or are they contaminating everything once the patient comes in? Next slide. And I added this, it's from NIOSH, because when we think about how do we best control those hazardous workplace exposures. So when we're talking about workplace safety and just general safety of our employees, the best thing to do would be to eliminate that physical hazard. So to be able to eliminate the hazards of manual cleaning is really the best control method. So if we could eliminate that manual cleaning step and automate it, that's truly the best way that we could keep our patients as safe as possible and control that hazard. Let's just eliminate the hazard altogether and automate the cleaning process. Next slide. So I wanted to provide you guys with links to the two machines that we have that would automate that cleaning process. So we could eliminate those workplace hazards. We would automate the cleaning steps, which would save time for your staff, which would keep your staff safer by eliminating that cleaning process. And these are the only two products on the market right now that automate the cleaning process. There's nobody else that is able to do that right now. So this automates the cleaning and the high-level disinfection processes. The Ethos is for endocavity and surface probes, so it cleans and high-level disinfects. The T-Clean cleans and high-level disinfects your TEE probes. This is kind of a revolutionary time for us where we can make sure that we're keeping our staff safe. We're really eliminating all of that guesswork and human error out of the process here. So all of those things that we were talking about, the time, the temperature, banging things against the sink, wondering if we filled the sink up with enough water, wondering if we put enough detergent, wondering if we took enough time or we're recontaminating with paper towels, all of that goes away with these machines. We can do all of that within these machines. No more test strips. For those of you that have ever been cited for test strips, no more test strips. We've solved that for you. You no longer have to worry about that being cited on your Joint Commissioner DMV surveys. So go ahead and scan these for more information or reach out to us, and we're happy to get these to you and give you more information. Next slide. And just to kind of bring it home, this is what your workflows could look like. So the left hand is your manual workflow. Everything is manual. Everything is cleaning, high-level disinfection. Everything is manual on that left hand side, and that's where all of your human error and also your chances for skipping things exist. So also in the middle there. This is where and a lot of people do have their TEE and endocavity processes. They have them, the high level disinfectant is automated. So you see those in the middle column where we have the green blocked out. That's the steps that get taken out when you have your high level disinfection process automated, which is great. At least taking that step is such a good step forward because that takes out a lot of risk and a lot of guesswork. But when you take that further step, and this is a step towards patient satisfaction, staff satisfaction, safety, all of the things, you can take out literally every single thing that you could possibly automate. And now all you have to do is the point of use, treatment, and transport. That's pretty much it. And then you're storing it, but everything in the middle you can take out. It's a lot of guesswork, a lot of steps. All of those chances for human error we can take out of there. It's so much easier with staff turnover, with competency training. So this is the way to go. This is the future, and we can help you with that. And this is the best way to keep our patients safe, to keep our staff from having to continually push themselves and spend all of this time. Next slide. Okay, so this is a really important slide, and I like to show people this slide because a lot of people want to do an ROI. So let's talk about something that would be helpful for our ROI. So if you're doing a totally manual workflow, what are we talking about in terms of staff time? Because staff time is money. We know that staff time is money. Staff time is effort. So I like to look at the hands-on time. So when we looked at how long you actually are hands-on with a totally manual workflow, it can be 48 up to 88. So up to 88 minutes of hands-on time with a totally manual. So that left-hand side of that chart I showed you. If you are manually cleaning but automated your high-level disinfection, it's 29 to 35 minutes of hands-on time. So that is hands-on your technicians or whoever is doing the reprocessing. If you automate everything, it could be as low as 9 minutes. So as low as 9 minutes compared to as high as 88 minutes is your ROI here, where we can improve that and let your staff go do something else, go do patient care, go do anything else, because they can put it in the machine and walk away. Next slide. So looking at a couple more things from the standards, competency training is one of the things that we get asked a lot about. A lot of folks are having trouble doing at least an annual competency or training, on demand basis because we know we have staff turnovers. We know we have a lot of new staff. We know we even have trouble with onboarding new staff. So this is just an excerpt from the most recent Joint Commission chapters. So it does say that examples of competencies may include donning and doffing in PPE, which is also very important, as well as the ability to correctly perform the processes for high-level disinfection. Joint Commission and DNV are very closely watching things like high-level disinfection. It is on their radar. They know a lot more than they used to. For those of you that have been doing this for a long time, they used to just walk in SPD, hold a tissue up to the vent to make sure decon had negative pressure, and they'd give us a thumbs up and they'd walk out. Now they really know what to look for. So below, you can also see how it correlates with with CMS. So this is important. Understanding where your risk points are with high-level disinfection, how you can simplify it, and how you can be compliant is just as important as knowing that it's better for your patient safety. So we want to make sure that we have your competencies up to date, which we provide with our service contracts on an annual basis. We also have web-based training that can make sure that you're up to date with everything on an as needed basis. And we also provide free webinars every week that your staff can also tune into as needed. Next slide. So again, from the Amy TIR 99, just to really hit home on some of this training and competencies, TIR 99 also says it should include or be included annually, or, which I think we all agree with this, if you have new equipment come in or you get a new device. So if you get a new probe in that you've never had before, we need to make sure that there's some in-servicing done on that. Or if you get a new supply, if you decide to use a new chemical or if you decide to use a new enzyme sponge, we need to make sure that you have some training on that. You also need to make sure that the people performing your reprocessing have been signed off and are deemed competent. I have seen a lot of people that roll in to these processing areas and they have no idea what they're doing. They just kind of watch somebody else. Maybe they're only there for a month or they're rotating through and they're like, well, they just told me to do this. That is not who you want to reprocess a semi-critical device or really any device. They need to make sure they are competent in all of the parts of the reprocessing steps. Don't just stick a resident or fellow or a brand new nurse who's never done a processing just because they're on orientation. This is not someone's job that you just stick there because they need something to do. This is important, vital work that has to be done to the T. Every piece of the process has to go right for successful high-level disinfection, and we can't skip steps. So please make sure everybody's competent. Next slide. I know this is a lot of words, but I wanted to include it because the IC standards are close to my heart. So 40101 about the policies and procedures for cleaning and disinfection. I won't go over all of them because I'm running low on time. But you do need to make sure that you read all of these carefully. But I really wanted to call out attention to the resolution of conflicts between medical device and the instructions for use for automated high-level disinfection. Just making sure that you have a plan for that, have a policy or protocol, so that if your equipment and your IFUs for your device don't match up, what are you going to do? This is something Joint Commission is going to want to see, but you also just need to have a plan. You know, what are you going to do with that device if there's something in the IFUs of the equipment and the probe that don't match up? Next slide. So talking about D&V, with the infection control chapter, a lot of stuff is under the surgical services chapter for things like probe reprocessing, but for the infection control chapter, the guidelines are to validate high-level disinfection to include the offsite locations to demonstrate compliance with policies and procedures and the manufacturer's recommendations. So no surprise there. But with surgical services, it talks a lot about the IFUs again. And I love this SR4 that says you shall allow adequate time for reprocessing to ensure adherence to all steps. So that's where it could get you in trouble with if you are manually doing all of these steps and you're a D&V accredited organization, then you have to allow all of the adequate time. And if you're manually doing all of these processes, that time is a lot of time. So we have to make sure that you're allowing all of that time, or you could get cited by D&V. Next slide. So I want to talk a little bit about storage, and you can again scan this QR code for our 7-day hang time study, which I'll talk about in just a minute. But there's a lot of question about storage, and I'm sorry I can't go into it more. But TRN 99 has a lot of information about storage as well. But I do want to draw your attention to our 7-day hang time study because there's always a lot of questions about how long should I keep something hanging in our storage cabinets. So what we did was we did a real world study about how long should we keep these TEE probes hanging. And what I mean by real world is you can't do a storage study and just keep the door closed with HEPA filtered air and say that's real world. Because in the real world, we know that the doors are going to be opening. It's going to be exposed to the environmental air, whatever is in that space over and over and over again every single day. So we did a study with our cabinets and then also a cabinet that didn't have HEPA filtered air. And we came to the conclusion that 7 days is really about the maximum that you can keep things hanging before they need reprocessed because you are going to be opening that door over and over. So read the study, see what you think. But really a risk assessment that um, shows why you chose what you did is really what you're going to need to do and to show why you chose to do that. Next slide. Here's some more storage guidelines from Amy TIR 99. I'm going to skip over it just a little bit because I only have a few minutes left and I want to get through the rest of the slides. But again, grab your copy of TIR 99 so that you can go over all of these storage guidelines on your own. Next slide. So we know that inappropriate ultrasound probe storage, and this will be listed in some of these guidelines as well. You don't want to use open air storage on or wall hooks, hanging on ultrasound carts, which I unfortunately see all the time, rolling through these departments. You never want to store it inside the shipping container that it came in. That's a very spongy, porous material that it comes in, and that is just a breeding ground for all sorts of bacteria. Never in those Tupperware containers or any type of bag. Wall tubes, we see that unfortunately very often, and definitely not on drawers or counters. Next slide. So this is a great example of an appropriate storage example. It's made for probes because again, when you store these probes, they have to keep that low level disinfected and high level disinfected portion away from each other. It cannot touch. And they're made for a certain amount of probes. So I have also seen people try to shove extra probes in there. So say it's a 6 probe cabinet, you can't store 8 probes in there because then things are going to be touching. So you do need to have probe cabinets made for probes and they need to be stored properly. Next slide. I wanted to touch just on hand hygiene quickly before we wrap up. We are just wrapping up a survey for the reprocessing decontamination areas. And this is something I really want all of you on this call to explore. And I'm talking to a lot of IPs about it because the recommendations for hand hygiene in reprocessing spaces is really vague. We don't have a 5 moments for hand hygiene in sterile processing. So just some preliminary data as we keep wrapping this up, that 47% said the nearest hand washing sink was greater than 6 feet from where they doff their PPE. And you guys know as well as I do, they will not use hand hygiene if it's difficult. So they are doing dirty work. They've had their hands in dirty water. They doff their PPE and the hand washing sink is super far away. They're not going to do it. So they're walking around with dirty hands. So we need to make sure that we are setting people up for success in these reprocessing spaces to make it easy for them. They also said that 22% said no, that hand sanitizer wasn't even conveniently located in their reprocessing space. And that is an easy fix for everybody on this call. You should all be rounding in your reprocessing spaces, even those in senior leadership, the department leaders, quality, all of you should be going into these reprocessing spaces and look around, see where the hand gel is, ask them where would be convenient because it's not up to us. It's where they feel it's convenient. And 29% said it's not even near where they don their PPE. That is easy, easy fix. If we want them to use it before they don their PPE, we have to put it where it's easy for them to use. So please make this something that you can go back and do immediately. These are easy fixes to make things easier for our staff that we can do to help them. So make this one of your goals over the next couple of weeks. Next slide. And just one more thing from our AMI guidelines. This is from TIR 99. There is a small section on quality improvement. And this is what you need to be monitoring on your ultrasound machines, your transducers, your endocavity probes, and your TEE probes. So on a regular basis, daily, per use, per patient basis, these are the things that we as quality folks need to make sure are happening every single time. If this isn't happening, then we're not making sure that our jobs are being done correctly. Next slide. I wanted to give you this QR code so that you can visit our resource page. Lots of free downloads, white papers, information, and resources. So please make sure that you visit this page and access all of our downloads. Next slide. And this is my new section of the website. I'd love it if you would visit it. You can scan this QR code to go straight there. Please take a look. Let me know what else you'd like to see there. There's already 4 articles there for you to take a look at and peruse, but I'd love it if you took a look there. Next slide. And we're really excited to announce that we have 2 full scholarships to the HSPA annual conference, as well as 2 full scholarships to the APIC annual conference. You can find these on all of our social media platforms. You also will receive an email for after you attended this webinar. I know some people were asking how you get your credits. In that email, it's going to ask you for your information so that you can either get your CEUs through HSPA or your IPUs through CBIC. So you will also respond to us that way, and we'll send you your certificate so that you can turn that in for your CEUs. I'm sorry we didn't get to all of your questions live, but I will make sure that I respond to each of you individually and answer your questions. And please let us know if you need anything else. If you can go ahead and go to the next slide. And this is my email. You can also reach me on the IP Insights website that I just showed you. If you just click Ask a Question, that goes straight to me. But you can email me directly here as well. And I just want to thank all of you for coming. And sorry we went just a little bit over. And again, that we didn't get to your questions, but I will make sure that I get back to all of you. Thank you all so much for attending this webinar today, and to the Leapfrog Group for partnering with CS Medical on this webinar and on this really important topic. I hope all of you have a great day, and we'll talk to all of you soon.